certain languages, maybe speak in a certain dialect. There's choices that are being made. And in some contexts, some languages might be higher up in the hierarchy. So today, at this, which is an academic or scientific conference, English would be the language that is at the highest point of the hierarchy. But there would be other options that we could use that would not be at the highest of the hierarchy, but would also potentially work. For example, we could speak in French or Yoruba or Pidgin English or whatever, but there's an active choice to speak English because this is at the highest of our hierarchy. But if we decide not to go with that choice and negate this hierarchy and go with some of the other options, there are certain situations where we could derive profit from doing this, from symbolically denying the standing of a certain language at the top and choosing a different option. And it will become a lot clearer with an example in a second. But finally, I want to make one more point here. If we want our audience to adopt a certain risk-avoiding behavior, our success rate of persuading the listener increases if we include personal experiences and highlight our shared culture and background. So essentially, what we need to do is we need to establish common ground with the community that we're trying to reach, or with the professional sector that we want to communicate with. We want to signal that we have shared experiences, that we share perhaps culture or background to show that we're on the same team. Because this then leads to trust and solidarity, and those are elements that I think are extremely important if we want to have an impact with our activities. Of course, there might be situations where you as a scientific expert or as a politician are communicating with a group that you don't belong to, that you're not an insider of. But that's exactly when we go back to the first point here, which is that of a collaborative approach. In those situations, it's extremely important that we collaborate with insiders, with cultural insiders, who already have this standing of trust and solidarity within the community that we can now build on in our own activities. I'll now talk about a few examples to really showcase how this can be put into practice. So what I just spoke about is also the data analysis that I discussed a couple of minutes ago. So first I want to talk about a workshop that GET actually organized during the Ebola outbreak in 2014. It was a workshop that took place in Sierra Leone, and perhaps some people here were actually at the workshop. And the workshop was held in English until the Honorable Commissioner, Professor Baimi, decided to not speak English for his presentation. He actively negated the established hierarchy. This was a scientific presentation, which usually would be in English, but he actively went against that status quo and decided to give his presentation in English, because he probably not even needing Pierre Bourdieu to explain this to him, but he had a feeling for this. And I'll just quickly read a quote from a person who was present at the workshop and describes the mood or the effect that this strategic choice had with the Ebola survivors. They just looked at us like they are not here to judge, they are not here to stigmatize, they are not here to make money. They're actually here because they genuinely care about us. And that difference was amazing. And this just proves how, with a simple linguistic decision, the entire outcome of our presentation of a workshop was changed. And this is something that's important that we need to bear in mind whenever we are developing targeted communication activities, that we need to speak the language that the local or the target community speaks. We need to use words that they understand. And that's also been brought up already a few times today. We don't think I think it was Dr. Wande Alimi said, we don't need to use our fancy words. We need to use language that people understand and that they see themselves. They identify with that language. Now I just want to quickly go back to some of the data I presented earlier. And as I was saying earlier, in Luxembourg we found that the construction sector was being hit quite hard as compared to other sectors by the COVID-19 virus. And So what did we do with this information? It's all well and good that we did the research, we understand that there's an issue in a specific sector, but it's not just enough to understand what's going on, but it's actually trying to change something and trying to use this information and then put something into practice that will address the shortcoming that was identified. So what we did is we first wanted to find a way to have a collaborative effort. As I mentioned earlier, it's important to have a collaborative approach. So we wanted to identify insiders to this professional sector. And the choice we made was that we wanted to collaborate with the workers' unions. So we approached the unions and we explained to them the situation. We showed them the data, we showed them that we identified a problem in this specific professional sector, and we asked them to help us come up with an approach to improve the current situation. So throughout a few meetings and focus groups, we then decided that the approach that we'll take is that of organizing workshops. So we organized workshops with over 300 employee representatives from within the sector of construction, and 300 in terms of Luxembourg. That's a lot because there's not that many people in the country, so 300 is actually a large number. And we organized 2 workshops with those representatives, one in the local language Luxembourgish and another one in French, because in our interactions with the unions we understood that a lot of people working in that sector actually speak mainly French and might not understand Luxembourgish, so we adapted to both audiences, both target audiences in terms of what language they understood and wanted to speak in. In those workshops, we explained the situation to the representatives. We tried to explain to them what kind of preventive measures they can take in order to really improve the situation, and we also started to communicate about, talk to them about the importance of getting vaccinated. And the goal of those workshops was to really develop ambassadors for us on the ground, because we want to have people carrying our messages onto the ground, people that understand what's going on the ground, that speak the language of the people that are working in this sector, because they're much rather going to listen to somebody who speaks their language, who knows what's going on in the field and who has experience in the field, instead of listening to politicians or scientists that they don't really have any connection with. So it was important for us to develop ambassadors that can carry on our messages in the right way. Now, before I wrap up, I also want to emphasize how important this kind of insight, so this kind of analysis that we did is also very important in terms of vaccination campaigns. If there are hesitations within the community in terms of getting vaccinated, if you want to effectively address those hesitations, and if you want to effectively communicate with those people, you need to understand who they are. You need to understand their background. You need to understand why they're hesitant. And exactly to get that insight, it's important to do that research, to go back to the way we looked at infection rates and hospitalization rates, and similarly look at vaccination rates, to see what professional sector, to see what country of birth or what age group is hesitate. Because with that insight, you can develop, again, targeted activities that really address those people in the right terms. Of course, it always depends on the data that is available. We are very fortunate in Luxembourg that we have very reliable social security data that we could fall back on and use. And there was a lot of work that needed to be done in order for the data to be made available and in an anonymous way, so that everything was data protected and GDPR compliant. But regardless of what data is available, the questions remain the same. We need to understand who the most vulnerable are. We need to understand where they're coming from. And whatever it takes to find answers to those questions, that needs to happen. We need to get creative. I mean, the pandemic has shown us that creativity is very important, also in science and in politics. So also to answer those questions, regardless of what is available, we need to be creative to get those answers. Because if we know who we need to reach, we can develop an answer to how we can reach them. But without that first step, we can't get to the second step. And with that, I just want to thank you guys for sticking around, and we can finally go to lunch. But thank you very much.
Thank you very much again for your informative presentation, Dr. Tom. So I particularly like that you addressed the communication bit, especially with vaccination, because I remember, and even with the COVID-19 pandemic, I remember hearing from someone that, oh, it's only rich people that get infected with COVID. I was like, oh wow, like, is that the assumption out there? So this communication has to be, like you said, a collaborative model of dialogue and engagement must be employed to communicate these things with people, because people are confused, people are clueless, and there is a lot of misinformation out there. Like my colleague was saying, it's an infodemic. There is so much going on, especially in this current age where WhatsApp, people are sending different, conspiracy theories, and we must communicate to people because they have to know the truth, they have to know what exactly should be done. Thank you so much again for your presentation. It has been a good day. However, we are not done. We'll go for lunch very shortly. We have 3 abstract sessions that will take only 10 minutes each. We crave your indulgence, please just hold on. The first one will be taken by Dr. Oluchi Joan Kama Okafor, and she'll be speaking on a qualitative analysis of the COVID-19 vaccination rollout in Lagos, Nigeria, clients and provider perspectives on the plan, the process, and the progress. Please join me as I welcome Dr. Oluchi for 10 minutes for her abstract. Thank you so much. I know that we are getting tired, but please just encourage. Thank you. All right, and we'll be done shortly. 10 minutes.
Good afternoon, everyone. I'll be standing on the existing protocols. Let's have the slides, please. I'm particularly happy about the presentations that have preceded mine, because they have sort of provided a background to what I'll be talking about. I haven't got a presentation showing in front of me yet. Am I going to have it here? Okay, while I wait for it, this is my study. It's a research paper titled A Qualitative Analysis on COVID-19 Vaccination Rollout in Lagos, Nigeria. And it's based on research on the events around the COVID-19 vaccination process in Lagos. We went out there and gathered information regarding how people were responding to the vaccine. And then in an attempt to answer these questions, we decided to look at qualitative assessment from the perspective of the vaccine recipients, the frontline workers, people providing vaccines to people, and then management, the authorities providing the vaccines, making them available. Can I have a bit of orientation on how to pronounce these notes? It's not working. This is not working. Okay. So the authors, as listed, are from various aspects of healthcare provision in Lagos. I'm from the University of Lagos, and if I can have the list of authors there, we have authors from the Lagos State Ministry of Health. We declared no conflict of interest, and for this study we received funding from the Lagos State Primary Healthcare Board. My presentation will follow this outline. So since the pandemic started, we've observed that vaccination has proven useful, especially in those countries that have successfully carried out mass vaccination. And vaccination immediately implies an epidemiological end to the pandemic. And so it's an important step for any nation to be inspired to. Most countries in Africa have started their vaccine rollout, but there have been challenges, especially like what we've observed in Nigeria. The challenges have seriously limited this process. Once it's been a learning curve, and I think for this process to go further, we should apply the things we have learned and apply them going forward. It's been slow in Africa, and because for one thing, we are relying on doses coming to us from other countries in the world. It's basically donations, and so many countries have had to reduce the support they would have provided for us because they have a local need, and so their needs have been prioritized over ours. In the entire for the entire population in Africa, we have received only about 1.3 million doses, and that's just to be able to address 1% of the African population. And so that threat of not being adequately vaccinated in Africa remains, and it has even though as we've gone further, it seems as though the possibility of receiving enough vaccines for individuals to be vaccinated is reducing. So this process has begun, people have accepted it, and what their problems. People are not exactly, they are rethinking even the decision they've taken. So the aim of this study is to provide as much as possible a realistic assessment of the vaccine process, deployment of the vaccines to inform our future activities when it comes to the COVID-19 vaccination, and using a qualitative approach to assess the plan, the process, the progress, and the entire process of the vaccine rollout in Lagos. This study was conducted in Lagos State. So in Lagos State we have 20 local government areas divided into 37 LCDs, that is the local council development areas. With an estimated population of about 24 million people, we have 4 public tertiary hospitals to cater to this population. I see my slides are no longer visible. So there's an estimated 24 million people in Lagos. And for this, we have 4 tertiary healthcare facilities, 31 secondary healthcare facilities, and then 227 primary healthcare facilities. Out of these 227, 57 of them are equipped as priority facilities, that they are called flagship centers. So these services provide 24-hour comprehensive care. So these are the health facilities that we have to work with in Lagos State. And the important thing is that there are linkages between these health services. So going by this, we have something going for us when it comes to health services. So resting on the strength of this health system, the vaccine rollout system was placed at the primary care level. And 88 out of the primary care facilities, out of the 227, were deployed for COVID-19 vaccination. So just a brief about the study site. It was conducted, this study was conducted in those 88 COVID-19 vaccination centers. It was a descriptive cross-sectional study, and it was conducted among the vaccine recipients, frontline workers, and the administrators of the vaccine rollout process. And how were the participants selected? Was a sampling methodology, using a stratified method of sampling from the list of the 88 sites in Lagos, the 88 primary healthcare centers. 8 were selected, and this is the list of the 8. The discussants, the interviewees, and the key informants that were part of this study were selected purposely based on their involvement in the vaccine rollout process. The recipients were recruited at the vaccination site at the point of receiving the vaccine, just after they had received their first dose or their second doses of the vaccination. And then the interviewees and the key informants were approached formally to be part of this study. Data was collected using qualitative tools, a moderator's guide and a focus group guide to sort of create a background for the data collection. And then we had, for the focus group discussions, we had 8 of them. Each of them was carried out at the selected primary healthcare centers. And each discussion had 8 vaccine recipients. The in-depth interviews were conducted at selected local government areas, speaking to particular health workers who were involved in the vaccination process. And in all, 24 in-depth interviews were conducted. The key informant interviews were carried out, interviewing specific people: the state disease surveillance admission officer, the state immunization officer, and then the state epidemiologist. So data that was collected was analyzed, first of all, by collecting a recording. Each discussion or interview was recorded with the consent of the interviewees, and then they were transcribed verbatim, taking into consideration the nuances and the different interpretations that the speakers give. For example, when we speak from this part of the country, many times we don't use just words. We use expressions, we use size, and take our voice high and low, and these were considered in this data analysis. Then the transcripts were reviewed. 4 members of the research team reviewed these transcripts. We did a thematic analysis of the data collected using a framework approach. So the different aspects that are being examined were put into the different frameworks, and then they were analyzed based on themes. And then it was taken further to ensure that this data was transferable, considering the cultural differences, professional differences between participants. And then the transcripts were read and reread, content analysis, then through several data meetings, the data was achieved. The point where the data was relevant was achieved. No coding software was used, and participants were not approached to reassess the findings. Then all ethical considerations were observed. Limitations were that these are purely the perspectives of the individuals involved in the study, and this study could have been strengthened by providing absolute proportions, for example, numbers of, depending on the responses, placing numbers to it, but the design of the study is qualitative. And then probably it was conducted too early in the study, in the period of the vaccination. So maybe if we conduct another study at this time, people's perspectives would have changed. The results. So this is the nature of our participants. They were mostly females. So the areas, the themes that were brought out here were recipients eligibility. People weren't sure. People didn't know who was supposed to have the vaccine. It wasn't clear to people. Then vaccine availability. Many people didn't know where to get the vaccines, and sometimes at centers where they thought they would get the vaccines, they didn't get them. Myths and misconceptions that brought a lot of issues out. Then conspiracy theories, as have been alluded to in this time. So we also looked at what the specifics of those challenges, and then looked at provider and client perspectives as to how this could be improved. Other areas that were brought out by the providers was the degree of protection offered by the vaccine. Some providers were in doubt. Then uptake. People were not coming to receive the vaccines. In the center where I work, this vaccine center was mostly abandoned. Then another issue was frontline workers' evaluation of the plan and the process, and it was evaluated that the logistics were poor. Sometimes there was inconsistent supply of consumables. Then on plan changes, a lot of things had to be done spontaneously. Then going further to the key informants, the completion of doses was an issue. Many times people were not coming for their second doses. Then the use of electronic data capturing, that was a good approach that strengthened the whole process. But we had problems of power and the problems of continuity when it came to that. So we had to revert to paper and use of cards and use of strips and sheets of paper. And we know the problems with those, they could be lost. Then partners, funding. We didn't get enough, the funding I was providing us for partnering probably wasn't strong enough, and they advocated for more funding and collaboration. Then other points that were found out was that the uptake had issues, and then for that it was proposed that a bottom-up approach could have been applied. Maybe if we had sought the opinion of the community and the people before implementing that plan, maybe people would have been more receptive if people got more knowledge about it. And then coverage. So there was this stigma associated with the vaccine, as we found out, and we thought about people, the proposed vaccine champions. They proposed targeted campaigns, and just like we learned about information, fact-based information, and then introducing counseling before and after vaccination to take care of all the unknowns and the surprises that came with the vaccine. And this same findings were found in other parts of the country, in other parts of the world. They're not exclusive to Nigeria. Many countries in Africa have things like this. So they want specific to Nigeria. But one challenge that we had was that even before doses were available in Africa, we already were burdened with the misinformation that came from the global environment. So it made the vaccine process more difficult in Nigeria. And yes. So the first phase experienced a lot of challenges, and it is hoped that the lessons taken from the first phase will be extrapolated to make this process even more successful in the future. One key thing that participants said was that we could incorporate this into the vaccine process in Nigeria. So in conclusion, it wasn't without major threats, and the main limitations were the internet network problems, misinformation, misconceptions, and this led to vaccine hesitancy, and then the adverse effects, a lot of confusion about the adverse effects. And then too few doses. Some people wouldn't take the vaccine because they were not sure about their second dose. And these are the recommendations from the participants. So the valuable lessons, including applying the bottom-up approach, more teams, more vaccine sites, more super sites, more vaccines, and then maybe local vaccine manufacturing. And this is the message that's taken. We have more work to do. We have to put more hands on deck as we go along. My references. Thank you.
Thank you very much, Dr. Oluchi, for getting to the end of the presentation regardless. Thank you. So she got a few extra minutes because of the technical glitches. We have 2 more abstract presentations, and they're strictly 10 minutes. We have Tunde Yadeka. Can you please come up for your presentation? He will be presenting an abstract on a mathematical model that accurately defines infections and death caused by SARS-CoV-2, paving the way for the identification of a revolutionary biochemical model for understanding microbial infections. Tunde, can you please? Okay, round of applause for him, please. Thank you. We have 1 more after this, and we'll go for lunch. Thank you so much. 10 minutes.
Good afternoon. Depending on existing protocol, but I'd like to do a special living recognition to Prof. By Dr. Obadoye and their teams, and all the distinguished participants present here, physically and virtually. I also stand on comments made by regional speakers, starting from Dr. Trevor Smith from yesterday. Professor Oluche of today, and most recently, Dr. Tom Rush, who just left the podium some minutes ago. As I call, please kindly take notes. I'm going at my speed because of the timing. But I would like you to listen to everything I have to say. Most of it is controversial. So please try and hear through the lens of the things that Dr. Roche and Prof. Oluche presented earlier today. As I go on, please try and jot down the slide numbers you may want me to discuss with you privately after I talk about it, or the questions you have for me after I leave the podium. I'd like to start with a direct quotation from the Nobel Prize winner in medicine. It's somewhat surprising that so little mathematical work should have been done on the subject of epidemics, and indeed on the distribution of disease in general. Not only is the theme of immediate importance to humanity, but it is one which is fundamentally connected with numbers. While vast masses of statistics have long been awaiting proper examination. But more than this, many, and indeed the principal problems of epidemiology on which preventive measures largely depend, such as the rate of infection, the frequency of outbreaks, and the loss of immunity, can scarcely be resolved by any other method than those analyses. Emphasis put there by Blackwood. My name is Tunde Yadeka. I work for a firm registered under the name of Research Plus Concepts. I'm the lead researcher for a consortium analyzing COVID data under the project name Black Hole. Those words were the words of Sir Ronald Ross, who got the Nobel Prize for Medicine way back in 1902, based on his mathematical work that led to issues that helped to eradicate malaria. The sad thing is that much of what Sir Ross said 130 years ago has prevalent today. The final table looks more like 60,000 than the 100,000 to 200,000. Those words were from one of the leading epidemiologists last year, at the beginning of the epidemic in the USA. Numerous statements like those have been made by leading healthcare experts and administrators since the inception of the disease. And the overwhelming majority of these statements have been based on little, or poor science or logic, leading to actions and inactions that have worsened the case. For those who like data, at the time that Dr. Fauci made that statement, US had just hit 16,000 deaths. 2 weeks after that statement, they were on the way to 30-something thousand deaths. A month later, they hit 60,000. 18 months down the line, the US reached 700,000 plus deaths. The 5 objectives of epidemiology, most people here know more than me, but 4 of those 5 depend on mathematical analysis, just as Sir Ross said 130 years ago. Back in 2020 February, my team noticed that most reports coming out from the models being used for studying the COVID infection were very inaccurate and in many times in error by significant margins. We surmised that these inaccurate models would sooner than later lead to bad advice to governments in terms of how to mitigate, contain, control, and hopefully stop the contagion spread. We therefore began to search for, and we found, a model that accurately describes and continues to describe infection and death rates arising from COVID-19. Our model has not only provided accurate values of reported events, but it has correctly predicted milestones that models used in the USA, the UK, and Germany did not. Specifically, what triggered the necessity for us to start making our findings known. By the 15th of April last year, our model was pointing to the fact that US will hit 60,000 deaths by the end of April. So when we watched the live broadcast where Dr. Fauci was predicting 200,000 deaths towards the end of 2021, we almost shut down. How could we be right if Dr. Fauci is saying something else? It's now history that US hit 60,000 deaths on the 2nd of May 2020. The slide is slightly wrong. Our prediction was 2 days late. And therefore, we now start to look more into our findings and extend our studies. When I say model, actually I'm talking of 4 different equations. I won't waste our time with that here on the podium. One of those equations in the model was applied to countries that had poor data. And the model predicted as far back as May 2020 that 3 countries, Brazil, India, and Nigeria, would witness explosions at times when those countries had relatively minor counts compared to the Western countries where infections were soaring. I want the health officials here to take notes. Back then, we predicted 10 million plus in Brazil by the end of 2020. We predicted 25 million plus infections in India by the end of 2020. We predicted 40 million infections in Nigeria from our model by the end of 2020. We all know now that Brazil and India are top 5 in the millions of infections. Why Nigeria is still telling us we have 234,000 infections is something we need to address in the line of Ocean's earlier presentation. We're able to make such bold productions even in those early days because we had applied the model to pandemic data from the past and found that the model was uncannily accurate with as little as 2 weeks of data. Specifically, we applied the model to data from the original H1N1 pandemic of 1918, the HDN2 of 1969, and the H1N1 of 2009. For those who are not so aware of statistics here, we got 97% rank correlation on 2019-18 data. We got 99.98 correlation on the 2009 data. At that point, we knew we were onto something. We went on to apply this model over 700 times as of June this year. I've been counting the applications from July to now. We've applied the data over 700 times in 64 locations around the world, and the statistical fit has been a minimum of 96%.